Good evening, everyone. A very warm welcome and thanks for joining today. Today is the International Childhood Cancer Day, we all know, and we all are over here to discuss the shared responsibility that is to ensure every child with cancer receives the treatment. That child should not fail by the delays, gaps, or by the system. So today we have very esteemed keynote speaker followed by a esteemed panel discussion where we are going to discuss about the translation of the policies into practice so that the care which we are actually have for the children where the childhood cancer is highly curable, it is actually able to reach every child with cancer so that without without any uh, resources, lacking of resources because of the geographic differences, these children should not suffer and they should be able to have all the facilities which can help them get the cure. With this, I would like to ask Dr. Yadav sir, who is our chairperson of PHO, to introduce our keynote speaker. Thank you, sir.
Uh, Good evening, everyone. Thank you, Shweta. So it's indeed a pleasure to be part of this webinar on International Childhood Cancer Day. And all the children in India who are suffering from cancer, they need a lot of hope, a lot of encouragement, and all the doctors who are treating, nurses who are treating, they all need to celebrate this day so that we can provide better care and improved survivals across India. And it's a pleasure to welcome today's speaker. Our speaker is Professor Dr. Ravi Kannan. Dr. Ravi Kannan is an oncosurgeon par excellence who is currently heading the Cancer Institute. It's a Kachar Cancer Institute and Research Hospital in Assam, in the eastern part of India, in Silchar. And he has established this cancer center for poorest of the poor people and providing cancer care to the needy ones. And he left his roaring practice and established career in a very big hospital in Chennai, where he was practicing oncosurgeon. He left that and went to the eastern part of India, where cancer services were not there at all. And it's indeed worthy to note that to make a difference, we need, if the people cannot reach us with cancer, we as doctors need to reach them and open new cancer centers in those areas so that people can access treatment. And he has been awarded with Padam Shri, which is one of the highest honors from the government of India. And he has also been awarded Magsaysay Award, which is like top award for public service in Asia. It's almost at par with Asian Nobel Prize. And so he's very, very revered and honored physician, surgeon who is involved in cancer care. So it's a pleasure to have you today. Dr. Ravi, over to you for your talk. Thank you.
Thank you. Thank you very much for inviting me to participate in this webinar. See, every year in India, 7,500 children are diagnosed with cancer. Many of them will be cured, but many of them may not be cured because where a child is born sometimes determines whether cure is possible or not. India does not lack policies, but then what we lack is predictability of experience for a child once diagnosed with cancer. So here in this webinar, there are people with many decades of commitment, and that is important. So what has happened in the last many years is a lot of progress. There are national programs, insurance coverage, there are guidelines, policies exist, centers of excellence exist. We have dedicated clinicians and NGOs committed to this cause. And there is excellence which is in pockets. But excellence in pockets does not deliver equitable care. The problem with our country right now is not one of policy, but of translation. The gap in childhood cancer care is no longer a knowledge gap. It is an implementation gap. Policies, stop at funding announcements. Guidelines don't translate into practice. Families often navigate the whole um, puzzle of care all alone. See, remember, children don't experience policies, they experience the care, the pathways that they negotiate. And what children need actually is early diagnosis that works in real life, where, awareness at the community and primary level leads to appropriate referral without too much of diagnostic delay, where a lot of care happens closer to home, not in big cities, but in their own smaller district hospital with a strong hub and spoke support model, where medical colleges and district hospitals are supported to deliver the care, not bypass. Often, what happens when there's a cancer, people will straight away go to the biggest cancer center in that region, bypassing their district hospitals, medical colleges. As a result, care is often fragmented. And then, where we can use technology to mentor and care, we need we need children children with cancer treated with child appropriate standardized treatment. There are uniform protocols. In the Indian Association of Pediatric Oncology has developed protocols adapted to our country. And so, but we need consistent supportive care and the reduced variation between centers. Center to center should not have too much of, difference in quality. What children with cancer actually need is protection from financial and social collapse. Often, in order to get their child treated, parents will often sell everything that they have and land up on the streets. Or at the other extreme, they will simply abandon treatment because they cannot afford the care for the child and the care for other kids at home. So we need beyond chemotherapy, we need coverage for transplants, we need coverage. So many other things happen. There's travel, there's nutrition, there's accommodation, there's loss of wages. And then we lack appropriate navigation systems that will support children with cancer. And then the whole care system has to treat the child and the family, not just the leukemia or the Wilms tumor. And we must manage pain, we must manage psychological support, both for the child and for it's so much more complicated for children. I, as a non-pediatrician, sometimes find it very um, bewildering to manage a child with a cancer who does not understand what is happening, who does not understand the suffering that is happening around him. And so it is a very big challenge. And then we have to ensure education. I know there are NGOs coming forward to do many parts of the story, but it's a long way off. And then we have to look at survivorship. And then compassion for children, I understand, is very different from the way we express compassion for adults. Compassion has to be operationalized through quality, through the familiar milestones of safety, efficacy, efficiency, equity, time, all of this. See, compassion without a system, it burns people's out. But systems without compassion, end up demoralizing the patients. We lose patience. And so we have to go through all of these milestones in order to ensure compassion. If we
Sir, are
don't, and
you
then,
showing your presentation?
yes,
We are not able to see the presentation, sir.
give me a minute. Are you seeing it now?
Yes, sir, we can see it. It has to be in
So
presentation mode.
it
Yes,
has to be in presentation mode.
yes. Now good. Yeah.
Sorry, I wish I had known this earlier. Okay, no problem. So, uh, so we must. But then, how do we measure all of this when it comes to children? When you want to apply a quality of life study, how I know there are there are quality of life studies from our own country as well. But I'm still wondering how we can apply these studies for kids. The compassion will ask, what is this child and the family experiencing? The quality in us will help say, what is the system change that has to be instituted that will prevent the suffering again? And then this is how learning happens. But then it is a challenge. The policy to practice gap comes at multiple levels. There's continuity failure. Patient in the community comes into a district hospital, comes into a cancer center. At every point, there is, restarting investigation, hundreds of needle pricks to be applied. And then kids are not able to communicate about survivorship. There is navigation failure. Families often carry the whole thing on their backs without anybody to support them. There is measurement failure. Remember, what cannot be measured will not be paid attention to, will become invisible. And then there is no one person to own the whole journey. And so integration of care becomes an issue. I think we need to shift. We have tremendous number of centers of excellence. There are several Tata Memorial Centers. There are AIMS. There are, centers with very good clinical experience. Many good things are happening, but there are no networks across the country, which we need to develop in the next 5, 10 years. If we have to change the way kids with cancer are handled, we have to create a network that will support patients across the geography of the country. We need from episode, when they go to a great cancer center or a hospital, they will experience great quality care. But when they come back to their homes, then the quality of care suffers, and there has to be a longitudinal ownership. From survival, we have to start looking at quality of life. From isolated clinicians who are amazing physicians and amazing surgeons, we need to develop dependable teams of nurses, of navigators. People will help patients go through the whole thing with a good quality. And then we have to ensure accountability, somebody to own the different. And so the government, the professionals, institutions, everybody has to pitch in. When I started the story, this happened many years ago. There is this child who had a leukemia. She had a leukemic deposit on the cord, and she came in with paraparesis. She was accompanied only by her grandmother, and um, there was no other caregiver. At the end of induction therapy, the child actually began to walk. And then the grandmother was extremely desperate to take the child home for a few. And so, against everybody's wishes, she went home. She came from a jungle dwelling in Tripura, and she never came back. And so we were very, very heartbroken at that point of time. And we made a decision that all kids with cancer will stay in the hospital for the duration of, because we realized abandonment rates amongst kids were very high. Fast forward to this year. This is Naitokti, another child, incidentally from Tripura. She came with a huge Wilms tumor. The whole abdomen was only cancer. And so we have support from Can Kids. We have several pediatricians supporting us for a um, 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 uh, weekly tumor board. And so, in connection with everybody, we gave her 4 cycles of chemotherapy. The tumor shrunk. They advised us 2 more cycles. And finally, we operated on the child. The tumor was removed. The surgery went off very well without any event. The first day she was well, and second day she just died suddenly. And so, after all of this, after so many years, we again lost a child for reasons that we could not fathom. And so, and we still have to audit the death of the child. But then what we realize is, single people cannot fix the issue of childhood cancer, and several people need to pitch in this. A child with cancer asks for, a policy alignment, asks for timely diagnosis, safe treatment, and a future. And we must have consistency in the quality of care we deliver, and that is not too much to ask. If childhood cancers are curable, then preventable suffering is, for the family also. Naitokti had no business to die, but she died. And so we have to avoid this kind of preventable suffering. And the problem is not of policy. It is of translation. It is of how all of us can join hands together to go that extra mile to bring about change. And so only then, when all the effort that we have put in over the years, our policies, our in expanding workforce, our ability to deliver CAR T cell therapy, all these and all the enablers, so many NGOs who are practicing all of this will translate finally into improved survival, reduced dropouts, and increased quality of life for all our patients. Thank you very much for giving me this opportunity. Thank you.
Thank you, sir. I think you highlighted the points very well. And it actually highlights the whole idea behind this webinar today, that how we can improve our practices. We have lots of policies on the table. We have a lot of implementation guidelines are there. And there is a lot of actually a trained workforce is also there. But we are not able to reach each and every child. Now, considering all these things, I would like to ask you, in the next 3 to 5 years, can you give us some idea, like if you need to change two things in the system, what are the two priority things you would like to change in the system?
Yeah, I think the biggest problem is the last mile gap. Kids live in far-flung areas of the country. Somewhere someone suspects a cancer, a retinoblastoma, or an abdominal tumor, or a leukemia, and they refer the patient to a neighboring big hospital, and the child does not reach the hospital. Who will ensure that the child reaches the hospital? Who will ensure that when the child comes to the hospital, the family is not lost in the um, jigsaw puzzle of papers and going from one OPD to the other, going for lab reports? Who will ensure that the child and the family understands that there is 1 month of induction? So who will understand that treatment is prolonged? Who will understand that at the end of 2.5 years of treatment of a leukemia, the child has a potentially long survival? So we need to, I think, the last mile care is probably the more. And when the child comes back, who will ensure that, like the child from Tripura, she comes back to the hospital? They don't default during several times during maintenance. Our kids don't come back, and then we go to their homes and bring them back. So that last mile ownership, I think, is the single most important thing. And if you ask what we as people who can advise policy or advise governments, I think it is investing in a workforce. It may be a nurse, it may be a patient navigator, it may be a social worker who will do this and create an audit system to audit the outcome of this. Instead of asking how many kids were treated, how many kids completed treatment, how many kids defaulted. The questions are not about how many kids did we treat, but about what was the outcome of all. Unless we audit what we do, we may not bring about a big change.
Perfect. So, just another question, interesting, which actually I always, when I listen to you and read about you, I would like to ask you, like, what inspired you to come to Assam? Like, from the cushy life of Chennai, and you have come all the way to Assam to develop a cancer center over there and to change the lives of people. What actually inspired you? And would you like to advise the youngsters, like, to take that path and follow you? How should we go about it?
So the hospital here actually was not established by me. People of this valley, lay citizens, farmers, tradespeople, engineers, lawyers, there are a few doctors got together and formed a cancer society to start a cancer hospital, because those days there was only one cancer in the entire Northeast in Guwahati, in the Bibarwa Cancer Center. And then at some point of time, their former director visited a number of cancer centers and he spent time with me at the Cancer Institute. And then one thing led to the other. They kept on asking us to come here. Initially, my wife Sita was completely against the idea bomb blasts and floods will not go anywhere near Assam. But then we came on a visit and she decided that, this is something worth doing. And so she said, let's do this because there is a tremendous need here. And we stayed back. On hindsight, almost 20 years later, I think we don't have any regrets. We have a complete sense of peace and fulfillment. And I think for me now, I'm not starting my surgical life or medical. I'm nearer the end of my professional career, and I think for all youngsters, I know there's a lot of things changing, a lot of more wealth is available. There's AI coming up. There's a lot of technology. There are high-end mall. All of this holds attraction. But ultimately, what will leave you with a sense of satisfaction is the people you have, whose lives you have impacted upon, the people who will come back to you even after a patient dies, they'll come back to you with more patients, asking for care. People who trust you with decisions about buying a car and, getting their kids married, and even though because they've had a cancer and becoming a part of so many lives, and then my own colleagues in the hospital also grow as they participate in care. And so the ability to do all of this leaves a very profound sense of fulfillment. And that is something uh, younger people have to experience to understand.
And very well said. I think the satisfaction in your job is the most important thing. And whatever you do, you should impact the lives and save some lives. Thank you so much, sir, for wonderful lecture and for what wonderful words of wisdom. Dr. Yadav, sir, are you there? Uh, I think so. We'll go ahead with our panel discussions now. And with this, I would like to introduce our esteemed panelists. Um, So with us today we have Dr. Gevorg. Dr. Gevorg is a Armenian pediatric oncologist and hematologist. He is serving as a professor and chairman of the Department of Hematology and Pediatric Oncology at Yerevan State Medical University. He is the president-elect of Pediatric Oncology East and Mediterranean Group, a collaborative network of almost 100 pediatric cancer centers across 28 plus countries. And he is also editor-in-chief of Onco Daily, a global oncology news and insight platform. Dr. Gewar holds advanced oncology qualifications from institutions like MD Anderson Cancer Center and Harvard Medical School, and he is deeply involved in international clinical research. We are very glad to have him over here. He's a very, very dynamic person and doing a lot of things to create, especially to create awareness about pediatric oncology. Next, our esteemed panelist is Dr. Regin. Dr. Regin is a professor of pediatrics and pediatric hemato-oncology at Istanbul University. She is a faculty of medicine and she's very globally respected expert in childhood cancer care. At present, she chairs the International Society of Pediatric Oncology in the capacity of General Secretary, and she has served in leadership roles with multiple oncology consortia, contributing extensively to research, clinical practice, and pediatric supportive care protocols. Welcome, Dr. Regin. We are very glad to have you over here today.
Thank you.
Dr. Girish Chinnaswamy, we all know him. He's a senior pediatric oncologist and head of pediatric oncology at Tata Memorial Hospital, Mumbai, one of the India's premier cancer institute. He is trained in pediatrics at JIPMER, Pondicherry, and completed specialized pediatric oncology fellowships in UK, followed by research in pediatric cancer, pharmacology, and pharmacogenomics. Dr. Chinnaswamy work focuses on evidence-based treatment protocols, survivorship care, and minimizing long treatment toxicity. He is also helping a lot of protocols, a lot of systems to develop to improve the clinical practices and outcomes for children with cancer, not only in India, but also in the Asian region. Then we have Dr. Alka Pisin. She is a CEO of Cancer Patient Aid Association. She is a patient advocate who brings the lived experience of cancer care in India to policy and practice discussions. Through her advocacy work, she highlights the real-world challenges faced by children with cancer and their families, including delayed diagnosis, access barriers, financial toxicity, and psychosocial burden of treatment. She firmly believes that a holistic cancer care is the way to go, and she believes from prevention to rehabilitation. Then we have Dr. Rajesh Kasla with us. He's a senior pediatrician and president of Indian Academy of Pediatrics, Mumbai. He represents the grassroots pediatrician's voice, which is often the first and most critical link in the childhood cancer care. He's been a strong advocate for early recognition of red flag signs and shared care models. His perspective is central to closing the diagnostic delays and strengthening referral networks. Welcome, Dr. Kasla. We are very glad that you have
Thank you.
joined. So, starting the discussion, I would like to ask Dr. I would like to ask Dr. Kasla only a few things. What do you think? What are the most common delays in childhood cancer diagnosis at the pediatrician level, and how we can help the system to overcome this?
Thank you, Dr. Bansal, for giving me this opportunity to be part of this program. Uh, so, if I mean, I'm a general practicing pediatrician in Mumbai. In our day-to-day practice, what we see the reason of delay in the diagnosis of childhood cancer is low awareness amongst the pediatrician as well as the patients themselves, I mean the parents. Because many times the symptoms that are there are quite confusing. The commonest being the prolonged fever, weakness, easy bruising, etc. Uh, we usually land up seeing lots of patients, and in that, the burden of patients, we commonly think of the common problems first, something like common infections and nutritional issues, and some other non-infective causes of the symptoms. And the suspicion of childhood malignancy remains quite low on the cards. No doubt there has been a lot of work done by the PHO chapter of IIP. The modules are running all in all the parts of the country, but still many a times yeah, it requires to be revamped and revisited again and again so that more and more pediatricians are exposed to these things. On the top of it, I feel in day-to-day clinical practice, if we have something like a ready reckoner or something like a checklist. For example, if I can correlate that with when we do the vaccination and we do the general checkup of the child, say 2 years, we have something called as autism checklist, which we hand over to the patients, and we are able to pick up those autistic children quite early. So something like this, if it is available easily to the pediatricians, that okay, these are the red flag signs which needs to be missed and which cannot be missed, and the child should be referred at the earliest. Second thing, I think we should also concentrate on a lot of activities where we can increase the awareness of parents, because when they come up with the symptoms, many a times there is a lot of masking amongst the symptoms. So if we also can have something for the parents, maybe running in our clinic, something like an audiovisual, which is continuously running in the clinics, which can give us some information to the parents of the symptoms of childhood cancer, that will help us a lot. And second thing is, I think there should be a regular and a repeated training of the pediatricians, getting them more and more sensitized with those red flag signs where they can pick up early, and early referral would be the key to the uh, diagnosis of childhood cancer.
I think very appropriately highlighted these points. We are doing a lot of pediatric, so we have a practical pediatric oncology training workshops are there. But as you said, that there should be a card like autism card where we can just have tick, 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 and we can see that these things are not there, or if they are aware, then how to go about it. So we can definitely look as a PHO chapter and we can work on it. Dr. Girish, from your perspective, what do you think, like how we can improve the childhood cancer care in India? Because you are working in one of the largest center where almost 1,000 children are coming per year. So what do you think, like how we can develop more better, more robust systems so that every child, this care, they don't have to travel to Mumbai or they don't have to travel other specialized centers, and they're able to get the care which they need at their place also.
Yeah. Yeah, thanks, Shweta. So, no, first of all, I agree with what Dr. Kasla said completely that we must remember that for a general pediatrician, childhood cancer is less than 1% of the workload what they see. For every 100 headaches they see or 500 headaches they see, there may be one brain tumor. So, to pick up that one brain tumor out of 200, 300 headache children, what they see, which have varied reasons, it's not going to be easy. So I think the chronicity of symptoms means that the child needs to be referred to a specialized center. That does not necessarily mean the child has oncological problem. It could be any other problem too. It could be a child who has got chronic fever or PO continuing, may have tuberculosis too, may have rheumatological disorders too, but needs to refer to a center where a specialized team can actually look at it or needs to be investigated if you have access to those investigations to look into those aspects. And all the training etc are very very critical because the first component is to diagnose the childhood cancer early if you can and refer to the right team at the right time and then get the right treatment, so which is all put in a nutshell. It appears very simple but there is quite complicated to do that in a heterogeneous healthcare system like ours. So one of the main problems we face, or what we see, being at the end of the journey of childhood cancer, when they actually are diagnosed or sent to us, is actually not only about the delay in diagnosis; it's about inappropriate diagnosis. When I mean inappropriate diagnosis, it's only not only diagnosis of the type of cancer, it's also inadequate risk stratification which occurs. So that means you start treatment of a neuroblastoma without actually identifying whether it is high risk or low risk or an intermediate risk neuroblastoma. You start treatment of an ALL without identifying whether common ones like pH positive or negative. So it tends to happen. It's definitely decreasing, but tends to happen significantly even today in interiors of states. So we need to address that. So how do we actually address that at the first shot when the child actually gets suspected with cancer? We not only diagnose the cancer, but we also identify what risk group the child belongs so that we can treat it at the right time, give the right treatment. If we do inadequately treat or over treat, then all of you know the consequences of that, which could be even having a poor outcome because of inadequate treatment, or over treatment could lead to toxic issues, which are a big problem in low and middle income countries. So I think that's the first thing we need to address. So education about risk stratification and appropriate diagnosis, what is mandatory to investigate in the beginning before venturing on treatment, is something we need to focus on, and that can be done only through national bodies. So what educate guidelines have to be pragmatic. If this what are mandatory tests have to be put in place, if this test is not available, we need to get the test done somewhere else, has to be put in place. And to a large extent the government policy has aligned with that, with the Ayushman Bharat scheme for example, ask for this mandatory test before funding is actually done. So from that point of view, to some extent, there is a movement to actually standardize this and get a uniform level of care. But that's the first component which we need to focus on, that we actually identify that as soon as you identify the cancer, you stage and risk stratify them well so that you then give the appropriate treatment. The second component is where I would say is that many times these not necessarily reach pediatricians. So they may come from brain tumors, they may come from orthopedicians, they may come from general surgeons, urologists, etc. We need to engage with those groups more so that it's not just about doing the surgery, but it's also about doing the surgery at the right time and also doing whatever needs to be done along with the surgery. So many times that doesn't happen, and so that is something which we need to engage. So we need to engage at a multidisciplinary level with various societies to see whether actually the child who comes with cancer gets worked up appropriately and gets referred to a multidisciplinary center where all this can be done. And there are of course many issues how to improve childhood cancer care. Financial toxicity is the big issue. Reaching a treatment center, how to keep them, which Ravi has very eloquently highlighted, the issues of keeping them there is a big issue. Then having a tired care model, shared care system would be extremely important in this, so that we actually diagnose and we are able to deliver care close to home so that it brings down treatment abandonment in a big way. So we must be able to identify what can be done locally and what can be done at the center. And these are areas where I think we should focus on. And critically, we should maintain data to know what we are doing well or what we are not doing well. I think I'll stop here and let others opine as well.
Very well highlighted, Dr. Girish. I think this is a very important point that not only the diagnosis, but the proper diagnosis and proper risk stratification is also very important, because we all know that the proper risk stratification makes a it plays a very big role in giving a proper treatment to these patients. And now coming to Dr. Gevorg, Dr. Gevorg, would you like to tell us from the global perspective, global oncology perspective, what are the things you have seen over in your institute, in your region? Are the obstacles to give a proper care to these patients? Are you facing any issues, or you're able to improve the care? How you're going up? How you're doing about it? Yeah. We can't hear you very
Um,
well.
yes, sorry. Thank you very much, Dr. Shweta. Thanks for having me in this great panel with these amazing speakers. Um, I think right now, I mean, we are in the 2026, and when I hear what we are like speaking, all of us in general, at the, I mean, we it's still the same what we would speak 10 years ago, 20 years ago, about the access, about the availability, about the disparities. So I think the critical point here is the time, and we must treat the time as we are treating the, let's say, the money, funding. Why I'm saying like this? Because I mean, already there are so many strategies exist all over the world. Millions of documents produced. There are protocols, there are, I mean, national strategies, international strategies, but the critical point here is on how we are going to deliver this to the patients, because patients actually cannot wait. And when we are talking about the statistics, okay, 400,000 a year, maybe more, patients are getting cancer, or like survival in one place is 60%, in one place is 80%, in one place is zero. And we are talking about the lives. And I think, I mean, I would not go into the differences, but I would go into the what unites us. Everywhere, wherever we are, like in any continent, any country, what unites us, it's like the empathy, compassion, and the willingness to make the change for the kids with cancer. Because child with cancer, or child in general, or a human being everywhere, he or she is the same, no difference. Of course, one size does not fit all, and in many countries we may have differences. But I mean, I think we have more similarities than we have differences. And here is like I'd like to talk about what we are doing at Onco Daily. And here it is when we decided that the everyone should have a voice, and if we democratize the voice, it's going to democratize the care in turn. So that's why, and the information awareness, this is a critical component which I think is very much needed. And that's why I think we need to spread the word, we need to spread the information, and finally, we need to deliver. We need to deliver all those strategies. And as I mentioned when I was talking about this, we need to treat the time the same way we would treat, um, I mean, the most important things, because really time is the most important thing, especially when we are talking about cancer. You know, we can get a lot of advices, and these advices can be, I mean, not can be, but I'm sure they are out of kindness. But the realities are different, and sometimes when we are getting an advice, okay, you need another needs assessment, or you need another beautifully designed strategy, we need to balance very well. Is it the thing what we need? I was visiting one of our friends, like in one of the countries recently, and we had a discussion with him. I mean, the most intelligent pediatric oncologists there are, very well educated, but still, I mean, they are getting this kind of advices. Okay, I mean, you need, for example, you can't start with the transplant because I mean, you may have more toxic deaths. But uh, I think we need to speak first of all. I mean, okay, if we don't do transplants, I'm just focusing on the transplant. If we don't do transplants, I mean, but all of them who need it actually will be lost. Of course,
Yes.
at the beginning, the toxic deaths might be higher, but at the end, when like everyone is starting from something, so I mean, again, as I mentioned, I think we need to find not the differences, but the similarities, and learn from each other on that regard. That would be my takeaway for the Childhood Cancer Day.
Yeah, thank you, Dr. Georg. I think these are very pertinent points. How to improve the care, how to escalate the care, so that we are able to give the care which actually every child or all the children with childhood cancer they need. So coming to Dr. Regine, you are now General Secretary of SIOP. And what is your perspective about how we should improve the childhood cancer care? Because there is a vast difference in the care in the Western world and in this South Asia Pacific region. What do you think? Like you have seen both the continents, and you know from very close how the care differs. So what is your perspective on that?
So thank you very much for the invitation, first of all. As you have said, I'm a pediatric hematologist, oncologist, and an emeritus professor of the Istanbul University. And currently, I am a professor at the American Hospital and Koç University in Istanbul, and the scientific secretary general of the secretary general of the SIOP, the International Society of Pediatric Oncology, where all pediatric hematologists, oncologists are together, and is the only, in fact, global pediatric oncology society. And I'm also the chair of the American Society of Clinical Oncology International Development and Education Award Program, and past chair of the past president of the Turkish Pediatric Oncology Group. And in my experience in almost 40 years of pediatric oncology, I have seen what can be improved, especially in low middle income countries, because we have gone through that scenario from in more than 30 years from where we have started and where we are now. First of all, February, on this day and all days, on February 15, which is the International Childhood Cancer Day, but in all days, we have to increase awareness of childhood cancer in the community, in the population base, in the nations, in the population, not only in the healthcare professionals, but also in the community, and also to inform the communities that today, if you can do a up-to-date treatment, you can achieve survival, a high rate of survival. Because in many countries and in many low-middle income countries, cancer is seen as a death statement. And and that is why many families, when they hear cancer, may even abandon treatment, as have been said. But of course, abandonment has other problems with it, other reasons for it. So we have to work in the local level, at the national level, in the regional and international level. And SIOP is one of the umbrellas that binds us all with the WHO, the Central Global, in many parts of the world, and the United Nations, because I'll be talking about what we have done as SIOP, WHO, Central, and member states and the United Nations. So what I think is that first, education is very important. This is education of the primary care physicians and the pediatricians, and also education of the community. And in that regard, especially the social media, the televisions and so on, are very important in the education of families. That I have seen a lot. So primary care healthcare physicians or pediatric hematologists, oncologists that can give some information, basic information in the early signs and symptoms of cancer for the children, for the parents, and also for the teachers. I have seen many teachers that have noticed some early signs and symptoms and have notified the families to take them to the doctors. Especially the school-age children. So early signs and symptoms, the education on early signs and symptoms is very important because we do not have screening tests as in the adults, For this, for example, in Turkey, when I was the president of Turkish Pediatric Oncology Group and also my other, the team members of our groups, we had done a program with the Ministry of Health together, not only us, because you have to involve the policymakers, you have to involve the Ministry of Health. And we went at that time, it wasn't online, we went to each city where primary care healthcare physicians and nurses would be invited for a 1 or 2 hour session on early signs and symptoms of cancer, and also on febrile neutropenia and nutrition. something that primary care healthcare physicians and nurses can help us with. This is important. But the other very important thing is that we have to force our ministries of health, our national policymakers, to have the childhood cancer in the National Cancer Control Plan, and to have universal health coverage, because this makes a huge, huge difference. Most of in the low middle income countries, especially, most families do not have the financial means to treat a child. You know, cancer treatment is a long and quite expensive treatment. So universal health coverage from diagnosis to treatment is very important. The family has to know that this will be covered by the government. So especially I can give you an example from Turkey, because from the 1980s, when we came to the 2000s, when we held the health reform and the universal health coverage, this has made a huge, huge difference, decreased abandonment almost to zero, because if the family knows that everything will be paid for, and that today, if you can get a good up-to-date treatment, you can achieve a high survival rate, they do not abandon treatment. We have seen that. And in Turkey, we have a Ministry of Health cancer register system, because one of the speakers, all speakers really mentioned very important things, and we have to have some metrics to know the impact of what we're doing. So having a cancer registry system, and so that we can know how many patients we have. I heard that you have 7,500 new patients each year in India, and in Turkey we have about 3,000 new patients each year. And in the Ministry of Health, we have the cancer register system, so we know how many children we have. We know the incidence. It is 1 in 140 million, for example. But we have done in the Turkish, the National Pediatric Hematology Oncology Societies are very important. In the Turkish Pediatric Oncology Group Society, we have a cancer register system, which is coordinated by most of you know, our dear friend, Professor Teser Kutluk, who was also the UICC past president, one of the past presidents of UICC. He's coordinating, and we're all really trying to do our best to put the registry. So we have the survival, and we have seen in 2008 we had a survival rate of 65%. Recently, in 2024, we had a survival rate of 71%. So it is increasing. With the education of the primary care physicians, with the population-based educations, with the social media, with the education in the medical schools, and also postgraduate education of the pediatricians, of the primary care physicians, pediatric hematology oncologists, but the most important, having the pediatric cancer in the national cancer control plans of the Ministry of Health, and having universal health coverage. So if the family does not have to think that whether it will be covered or not. This has made a huge, huge impact in the survival rate, and also in decreasing the abandonment rate. I think this is the most important thing. So we are working as SIOP, as the International Society of Pediatric Oncology. Also, we are working on it on the international level. Of course, the WHO is very important. You know, the WHO, the World Health Organization, has initiated a global initiative for childhood cancer in 2018. So that the aim is to reach by 2030 a survival rate of at least 60% in the highly curable cancers, which are acute lymphoblastic leukemia, non-Hodgkin lymphoma, Burkitt, and Hodgkin lymphoma, retinoblastoma, Wilms tumor, and low-grade gliomas. And this can be achievable. And in fact, the early diagnosis is very important. So we have to know about the early diagnosis so that we can diagnose these children. Then we have, as Dr. I think Kasla had mentioned, that we have to have the correct diagnosis, the correct staging, so that we can do the treatment accordingly. And then we have the follow-up. And each country, each center, each region has its own challenges. So we don't have one solution fits all. This is not it. We have challenges in every other country. And in fact, it is very important what Georg said. It is important the way that we respect the cultural differences and the socioeconomic differences of each country. We can make makeshift solutions according to the setting. We don't have a solution for example, that it was very important what Dr. Kanan said, because if they go home, they will not come back. So although this can be done as an outpatient treatment, we had them in the hospital, he said. This is very important. We did that with the refugee children. In 2011, we had 6 million refugees from Syria, and we have a lot of childhood cancer within these refugees. And we treated them all with universal health coverage. They were all covered by the government, but they didn't have a place to go where they could eat and be cared for. So we had to make makeshift solutions to keep them in the hospital. And also for our own Turkish patients also, if we know that the socioeconomic conditions are not good and they will not be we cannot rely on compliance. We have to keep them. For febrile neutropenia, we say if it is it is not high risk, it's standard, you can do an outpatient treatment. You can do that only if you have a compliance and you can rely that the families can bring them back home, back to the hospital very, very quickly. If not, you have to do what your local problems, your challenges are. You have to work for them. So what we have to collaborate for this. We have to collaborate on the local level, on the national level. The national pediatric hematology oncology societies are very important. I'm very proud that you're doing this for India. This is a very important initiative and very important educational activities. We have to do it in our on our regional with regional collaboration of the countries, and also we have to do in the international level. And in the international level, the SIOP is one of the umbrellas that brings us all together. The WHO is also very important. And as you know, in the United Nations General Assembly in New York in 2023 September, I, as the Secretary General of SIOP, had done a speech, and also many other stakeholders, on universal health coverage. This has to be done in all countries. And this year in 2025 September, we had a very important meeting that was organized by the WHO and the member state of Uzbekistan. And we as SIOP has participated, and 40 delegates of 40 countries, including Turkey, had participated. And on December 15, the fourth high-level declaration on non-communicable diseases and mental health was approved by the United Nations member states. This is a very important step, because for the first time in the United Nations, it was in the declaration to have the childhood cancer, the global initiative of childhood cancer, because this is something that we can force. Each country can force their ministries of health and their policymakers. There was another important thing on hepatitis B vaccination. This is also very important. In Turkey, from 1980 to the...
Yeah, sorry, actually, we have few other questions. Your point is very well taken. You're very, very passionate about childhood cancer. We can see that.
Yes.
And I think you have very rightly said that the policymakers should be there to actually help us. We alone cannot work on this. And we need policymakers so that at different levels we can improve the care. Now, coming to Regin, I'll come back to you.
Thank you so much. Thank you so much.
Thank you so much.
We shall work internationally all together.
Yes, we have to work together. Yes.
That is healthcare professionals, survivors, families, and also the NGOs. All together, we can make a difference. Thank you so much.
Yeah. And we are very glad that we have Alka, who is a CEO of a very prominent NGO in our country. And Alka, you have heard all the points, and you actually deal with the patients directly. From your point of view, how we can improve the patient advocacy, especially for the children, because we know that children are not the vote banks, and they definitely suffer because the policymakers are not looking at them, not because they are not vote bank, because the number is also very small. So as we said, that the policy is very, very important, and having a funding for the treatment is also a second, which is very, very important. So what is your take on this?
So thank you firstly for giving me this opportunity to be a part of the panel. And it was inspiring to listen to all the experts talk about all the issues related to childhood cancers. Being a part of an NGO that looks after approximately 400 new childhood cancer patients each year, and at any given time, we are looking after about 1,000 patients who are at different stages of treatment and survivorship with different types of needs. So we have to, as an NGO, we are walking hand in hand with the patient and walking their cancer journey with them, trying to support them in a holistic fashion so that treatment continuity is given priority and we do not have a situation where there is abandonment of treatment by any of our patients. However, I do feel that even in tier one cities, this is happening in silos. So we have been able to achieve this, but it is only restricted to a few organizations or a few groups that are working in this fashion. We need to have an organized structure which clearly defines different roles for different NGOs in sync with what the healthcare professionals want and based on the strengths of the NGOs. Depending on that, if each of us are aligned in a structure, then there will be no duplication of effort, optimum utilization of the funds that are available, and we would be able to increase impact. So if something like this was organized, maybe under a national body like the National Cancer Grid is already working in those lines, whereas the medical area is concerned. And I know that the civil or the NGOs are not a priority for them. Yes, we are a support for them and they acknowledge that at all times. But this structure would be really, really helpful so that you can combine all the funding that is available. You can combine efforts. It's not that five people are doing the same thing and actually there's a you know imbalance in availability of assets that is there for childhood cancer patients. So we need to have a proper structure in place. I think we are seeing that with change of time even in the silos. So we have hospitals and organizations which are doing that to some extent, but it is very isolated. So it's not only about continuity of treatment, it's also about follow up after or during survivorship. When a patient is fully considered to be treated and leaves the hospital and goes back to his town, he really is totally isolated. He doesn't know how to attain anything. He doesn't know what's he going to do if he has issues related to survivorship. Is there rehabilitation resources for him? Is there socioeconomic support? So he gets totally isolated in that sense, and we really don't have much in that area. So collectively, there are gaps. There is a lot happening, but it and every drop, it's drop by drop we'll get an ocean. But if we had structure around it, structure which connected us to policymakers and healthcare professionals with guideline, I think we'd be able to deliver and create a much larger impact in this area than what we are doing currently.
Yeah, thank you, Alka. Very well highlighted these points actually. And I think we need to have a structure. I would like to ask Dr. Gillit, you are working with the National Grid, Cancer Grid very closely. So what is your idea about it? How should we involve these NGOs more effectively so that, because they are working at a ground level and they can actually help the pediatric oncologists to reach every child. So how should we go about it?
Yeah, no, thanks, Alka, for highlighting that. So, all the non-governmental organizations are very, very welcome to join the National Cancer Grid. It's a simple application, takes only 5 minutes. There is no fee or anything to be done, and all of you are part of it. Of course, all NGOs, all people involved in the management of cancer, children and adults should come onto the platform because there are many advantages and many mechanisms and initiatives put in place which everybody can access without any burden for doing that. So from that point of view, we would encourage everybody to join. And also from a pediatric perspective, as you know, we are now in the middle of finalizing the guidelines for the country, which will be used by the government for funding childhood cancer treatment. And those guidelines are going to be out by end of the year or early next year. And so we have requested even patient advocates, NGOs to be part of it. And because we may look only from a medical perspective, the NGOs bring in a completely new perspective from the patient side, look at the issues the patients face, whether it is actually possible to deliver the care, what we are putting on paper in the guidelines, whether it's actually possible that input or that feedback is required from them, and where can they actually plug in the gaps for delivery of care. It is a very complementary thing. It is not either or. It's actually both have to do together. We all know that the medical system can only provide so much, and there are huge gaps outside the hospital which the NGOs need to cover. Otherwise, abandonment of treatment or non-completion of treatment will be extremely high. So from that point of view, we would welcome all of them to join and should be part of it. It's a multi-stakeholder advocacy group and multi-stakeholder group, so everybody should be joining that.
Yeah, thank you. Thank you for clarifying this. And I think encouraging everybody to join National Cancer Grid, I think this is the way to go in India now if we want to be a part of the system where we want to improve the cancer care. So with this, I think we are already on time. And to ask Dr. Rajesh, what is your take now? You have heard everybody, and I think you are the person, pediatricians are the people who come first in contact with the child who may be suffering from cancer. So how you are going to counsel these patients, and what is your take on?
Oh, yeah. So if I speak on behalf of IIP right now, say a body of 1,500 pediatricians here itself in Mumbai, yeah, my first and foremost thing would be try and sensitize as many pediatricians towards, those red flag signs so that they can pick up things early and definitely make something like a grid where we know where the centers are available, easily accessible in the peripheries of Mumbai also, and not only in Mumbai but other parts of the country, and try and also do lot of community activities for parents to sensitize them about all the different symptoms that they should be aware of, and so that they can come to us in time and things can be diagnosed early. So this is what my take would be. Spread as much as possible to each and every pediatrician who is dealing with the kids.
I think we'll work more actively on this. We are already working on this, but we'll make sure now like more activities are done from the PHO side so that more training of the pediatricians can be done, maybe online or offline, both together. And I think we are coming to the end of the session, and I'm very thankful to all the esteemed panelists and our keynote speaker, Dr. Ravi Kannan, who has spoken today on this eve of International Childhood Cancer Day and highlighted the various points, actually, how we can improve the childhood cancer care. And the main vision for us is to reach each and every child, irrespective of the geography, irrespective of the distance, they should get the care. And Dr. Warrior, you are sending a lot of messages. If you are online, can you unmute yourself and please speak few words? Dr. Raj Warrior is a senior member of a PHO group, and he's there, and he's very active member. And I would like to ask him, and he can say the last word for the session.
Shweta, I think, thank you very much. So nice to hear all of you. But I think the PHO should take a lead in these things. I'm an old member of that, but we have educated a lot of people, but I think we should go even broader, involve not just the hematology doctor, pediatrician, local level people, but also be involved politically because we are very quiet. So through IAP and through ourselves, we should get involved politically, make sure that the government, state, city support hemophilia, sickle cell anemia, also cancer centers. So I think very active politically, education-wise, and general education. Everybody should know about cancer. That's my. So good to hear all of you. I'm so proud of all of you guys. Thank you very much.
Thank you. I think with the senior member advice and his points, I think I would like to end this session thanking everybody, all the delegates and all the people, senior people who have joined today. And I think we can all work together to improve the childhood cancer. That is our mission and vision as well. Thank you so much.
Thank you. Thank you. Thank you.
Thank you, ma'am. I'll end the session.
Thank you.
Thank you so much.
Thank you.